A very good morning to all of you. At the outset, I would like to thank Dr. Mahesh, Dr. Digvijay for including me in this IC. I'll be talking about electrophysiology and neuro-ophthalmology, case-based discussion. So electrophysiology should be an aid to clinical examination, which has been just discussed. It helps in checking the afferent visual pathway and quantifying the defect. An afferent visual pathway, as was told, these disorders comprise almost half of neuro-ophthalmology, efferent being the other half. So what are the tests which come in electrophysiology and are useful to a neuro-ophthalmologist? Flash ERG. It is the mass electrical response of the retina to photic stimulation and is useful in determining the clinical status of the retina. So now when these patients come to a neuro-ophthalmologist, when the fundus is normal and the patient has poor vision. So in these simple cases like CSNB, congenital achromatopsia, cone rod dystrophy, retinitis pigmentosa, sign pigmento, cancer-associated retinopathy, fundus is normal to a general ophthalmologist and the patient comes to a neuro-ophthalmologist. A simple test as flash ERG can pick up the diagnosis. A variation of ERG is pattern ERG. It has three components, N1, P1 and N2. N2 represents the ganglion cell activity. So this ganglion cell activity gives an indication of the optic nerve health and hence it is being used in certain conditions of optic neuritis. Another variation of ERG is MF-ERG. It allows detection of small foci of retinal dysfunction. So it is useful in maculopathies. Again, very subtle changes in the retina. Fundus appears almost normal to the general ophthalmologist in conditions like HCQ, toxicity in azure. And this test, MF-ERG, can help in picking up the condition. Visual evoked potential. This has been, this is almost what you can say is as the previous doctors have discussed, that relative afferent pupillary defect is in the clinic itself, it helps in clinching the diagnosis. The objective part of that can be VEP. So it is as good as relative afferent pupillary defect, but it comes on the, it becomes objective that you got it on the paper that the patient has an afferent defect. So it records the occipital lobe brainwave potential in response to visual stimulation that begins at the retina and ends in the visual cortex. All this while we were talking about the eye from cornea to retina. This is right to the occipital lobe. So what are the indications in optic neuritis where there is RB and retrobulbar optic neuritis? Fundus is again, disc is normal. There RAPD has picked up the diagnosis. You do VEP and you will get a flat wave that shows that the patient has optic neuritis. In malingering patients, if there is no RAPD and VEP is also normal, you know that the patient, and fundus is normal, you know that the patient is malingering. And in traumatic optic neuropathy also, it's very useful in prognosticating. Now, MF-VEP is an electrical, it's a variation of VEP. It's an electrical response to the central 22 degrees. And its indications are objective topographic assessment of the visual fields. MF-VEP also shows defects not yet present in automated perimetry. So now we look at some cases. The first case, this lady has come to us with complaints of vision since past 1 month. I have intentionally put the whole case file here. You just look at this. The patient has given the history of diabetes since 20 years, malaria 1 year, and all the details of the drugs have been given here. And she has this recent onset decrease in vision. Her vision is counting fingers 2 meters in both the eyes. Color vision is 0/21. And her fundus is, it's a retinopathy, burnt out retinopathy, lasered, well lasered. Disc is normal. Macula is not explaining counting fingers. That's how the patient has come to the neuro-ophthalmology clinic. Now what do we do? And color vision was 0. So we did a VEP. And VEP is showing reduction in amplitudes with delayed latency. Now, what has happened is, after that we took a detailed history. I wanted to share this case report that tuberculosis still is, as a disease, people don't come out with the history. You have to really take the history. They don't, she gave all, the malaria some years back that she had, but she did not talk about tuberculosis and she was on ATT. So many times what happens, there are associated conditions like diabetic retinopathy, cataract, and this gets completely missed out, and the patient continues to take ATT, that is ethambutol, and lose completely the vision. So this patient had basically regressed diabetic retinopathy with toxic optic neuropathy. So VP was the test which clinched the diagnosis because it was bilateral, RAPD was not there. Now this is another case where electrophysiology comes to help. Here you can see that patient's been on chloroquine. In early cases, electrophysiology is of real use. Here the visual field's normal, OCT is also not picking up. Very subtle changes on the left side. You can see the peak is getting lost on the left side. This is a picture of a multifocal ERG. You can see that there is this is the foveal peak. Here you can see in the right eye it's good, left eye it's beginning to get decreased, and usually in established cases the whole area becomes blue, but that is, by that time you have changes in the fields as well, but earlier the better when you inform the patient. So these are subtle changes only seen in MFERG. Now this is another patient, again very subtle changes, where you can see in the right eye the peak is lost here, and the patient was advised to stop, and after that the patient came some 6 months back, and again very healthy macula. Now in this patient, 20-year-old boy who came with subacute vision loss, right eye followed by the left eye, and vision was 660. You can see a little bit of hyperemic with telangiectatic vessels, and we did a VEP which showed that there was a reduction in amplitude and delayed latency as well a little bit, that was confirmed with gene testing. This 56-year-old female came to us for CNVM in the left eye, and on history there was history of taking CARBOPLATIN. You can see there's a CNVM on the left side, but visual fields, because she was complaining of mild change, some visual complaints on the right side as well. This is her fields, and look at the multifocal ERG. The patient has, because of the CNVM, a lot of changes on the left side, right side also, there is something happening. Now in 50-year-old male, female coming with BCV of hand movements, normal fundus, you do a VEP and it is normal, you know it's malingering. Whereas in optic neuritis, vision of 6/6, left eye hand movements, VEP is flat on the left side. So this is not malingering, this is optic neuritis. That's how it's of. Now this patient had a 31-year-old female with right eye vision of 6/12 and left eye of 6/9. This is the fields, and ISOS junction change defects on OCT. And in suspected cases of Azure, MFERG is the investigation of choice. Cone rod dystrophy and retinitis pigmentosa, I think all these are well-known things.